Welcome, everyone. My name is Dr. Benjamin Galen. I go by Jamie. I'm the editor-in-chief of POCUS Journal, and I'm so excited tonight or today, whenever you're listening, because we have two co-authors from one of the research studies in the April issue of POCUS Journal. The article is The Impact of Point-of-Care Ultrasound in Medical Decision-Making, Informing the Development of an Internal Medicine Global Health POCUS Curriculum. And we have Michelle Fleschner here and Stephen Fox, as well as a special treat. We have Gordy Johnson, our POCUS Journal Global Health section editor, on as well for tonight's podcast. And I'm so excited to hear from them. I'm going to stop talking, but I'm first going to ask them to introduce themselves. Michelle, Dr. Fleschner, we'll start with you. We'll just tell us a little bit about yourself and tell us also, as Gordy would say, what was your first kiss with POCUS? When did you find and fall in love with ultrasound?
Sure. Thank you for having us. So I'm Michelle. I am currently talking to you from Denver, Colorado. I'm a hospitalist at University of Colorado Anschutz. I do a lot of POCUS development and POCUS teaching. My interest in POCUS started in Pittsburgh, where I went to residency with Steve and did the global health track, spent about 5 months total in Malawi, and learned how useful POCUS was there. And that's where I really kind of developed my skills. And I think that's where my first kiss with POCUS was like the first day in Malawi on the wards. We saw like 3 different pericardial effusions that were all to TB, and all had fibrinous stranding. And it was just really crazy and really, really cool. So that's kind of my POCUS background. Other things about me: I like to hike. I have 2 cats. Really like coffee, really like wine. Fun facts.
Amazing. I can't wait to hear more about the global health track. I want to remember to ask you about that. Steve, tell us about you.
Sure. So I grew up in Philadelphia, then went to Pittsburgh for residency, and I'm currently in Cleveland. And I'm in my 3rd year of pulmonary critical care fellowship. After finishing here, I'm going to Birmingham, Alabama, to University of Alabama, Birmingham. So, and before I mentioned about my POCUS first kiss, I have to say I'm a big fan of actually this podcast and the POCUS Journal, and so I'm honored to be here. And anyway, I don't, because I'm listening to the other podcast episodes and hearing about POCUS first kisses. I don't really have one, but I can tell you kind of a little bit of my story and how I got so interested in it. And to be honest, it was like from day one. So we had actually as part of this global health track, we had a 1-week introduction to POCUS, which was during my intern year. It was like October of my intern year. And I think it was like the first day of that, I just immediately fell in love with it. And basically after doing that 1-week course, I kind of just used ultrasound in an educational scanning fashion all the time, whenever I had the opportunity. Every rotation, I kind of just found a machine and, did educational scanning, whatever context I could, and clinical scanning if I had appropriate supervision. And I kind of just at that point made a decision to make it a big part of my practice, and have been that way ever since. So anyway, but the other thing I think that was a big thing for me that was a big selling point for POCUS was just ultrasound IVs, especially as an intern. When you have a patient whose kind of care is being limited by lack of IV access and lack of ability to do blood draws, and you can go and use ultrasound and somehow do it, it's kind of like a magical tool to help the care of your patient. And anyway, the rest was history.
Amazing. So great to hear your story. Gordy, tell us about you and your, I guess, your first kiss, since you coined the phrase.
Yeah. So I'm Gordy Johnson. I'm a hospitalist here in Portland, Oregon. I work for Legacy Health System, and I'm the director of POCUS here. We have 6 hospitals and now 2 residencies. But I've done a lot of global health over the years. First starting in India, I did some of my medical school training over there, and then on to Haiti and Africa. And lately I've been going to find my ancestral roots in teaching POCUS in Norway, which has been really exciting. I like learning languages. I've learned Hindi and a little bit of Creole, and now working on Norwegian. And I like to surf and play guitar, be in the outdoors like a lot of people in the Pacific Northwest. And I've been working for International Medical Corps part-time as well. So my first kiss, I think, was when I was rounding with the residents, and we were trying POCUS kind of on our own, didn't have any real formal training, and we had a heart failure patient. And this is a common one you'll hear is we put the probe on it. It wasn't my patient, but lo and behold, there was a huge pericardial effusion. So we called the team that was caring for the patient, obviously stopped the Lasix. And that's when I decided to go and do a fellowship in point of care ultrasound and really pick up the skill.
Amazing. It's really inspiring to hear, especially with the global health work that you all have done. It's really impressive. And I think this article, highlights some really important work that you've done in internal medicine education and overlap with global health. One question I had to start out, for Michelle and Steve, I'm really curious, especially for the global health listeners, what existing curriculum there was in that global health track that in your residency in internal medicine, because I think that's such a novel thing to have. And then, what was the gap that prompted you to innovate in this way with this curriculum and also evaluate it?
Yeah, so I think both of us chose UPMC as a residency because of the global health track. I'm speaking for Steve too, but I think that was a big factor in why both of us went there.
For me too.
And it was unique in that we got to spend 4 months abroad, which is more than average. And they had a POCUS curriculum already in place. And so what existed, and what I believe still exists, is a week-long, like Steve was talking about, a week-long intensive POCUS course. So we each had like a month of global health elective. And then within that month, there was a week-long course of hands-on scanning with some of the pulmonary critical care faculty. So hands-on scanning, really just a lot of scanning and some lectures and things like that. So that was really the intro and where we kind of got comfortable-ish scanning. As you all know, a week of scanning can quickly lead to then forgetting how to scan shortly thereafter. So what ended up happening with a lot of us, and me in Malawi specifically, as we got there, had a lot of basic skills, but then we're seeing all of this crazy stuff and not really knowing like what to do with it or what we were seeing. And so the gap that we were trying to fill was being able to develop some kind of remote longitudinal curriculum to be able to send our images back to the States, get feedback, for our own learning, and also because we were kind of independently caring for patients, and POCUS was such an important part of caring for them. And really, we didn't have much supervision there. So trying to kind of create that structure for our learning and for our patient care to be able to develop our skills of interpreting and clinical integration.
Got it. And one question I want to let Steve answer also, but the faculty that we're teaching, are they global health faculty, or are they teaching basic POCUS that then the global health learners go on to use? I mean, are they aware of global health applications, like some of the TB exam, like the FASH exam? Is that something that they were familiar with, or you sort of adapt that to your own application?
A little bit of both. They were all part of Pulm Critical Care. One of them, though, had spent like a year in Rwanda, and so had a lot of global health knowledge and a lot of knowledge as to how to incorporate POCUS. But they weren't part of the global health faculty in the sites that we were going to as residents.
Got it. And then by way of background, Steve, you also, you found the POCUS curriculum in the global health to be a great start, but that you wanted to take it to kind of the next level and really evaluate it's sort of a novel study. I mean, I think you say in the article there really hasn't been other studies that evaluate ultrasound applications in ion-based curriculum in low and middle income countries. So you guys came together to collaborate on this in your time while you were there, or in advance, or how did that come about, the idea to the curriculum and the study?
I think it was kind of as it was ongoing. I think a big part of it, kind of as Michelle mentioned, is we were trying to improve the system that we had. We were learning ultrasound, but of course needing a continuing feedback system, to continue to improve our ultrasound skills and make sure we were doing it right. So a big part of this, I think, was a motivation to do it better and to do it the right way, which I guess goes along with kind of POCUS quality assurance in general. But POCUS quality assurance is challenging enough within the same institution with a software system. It's you can imagine it's even more challenging across the globe. With especially, we didn't have any specific method for doing QA. So that was a big part of it, actually, was developing the system to do that. And we didn't have a lot of resources to do that in terms of money or dedicated faculty time, these types of things. So it kind of was a sort of a grassroots effort on our part to develop this system using like open source technology. And then by doing that, we were able to keep track of everything. A big part of it too was kind of a building of the community of people, because one, it was within the global health track residents, the people who are doing the scanning, to kind of be interested in using the system and see the benefit of it. Part of it was the community of the people who be doing the reviews, and this was all volunteer, and so it was people who were believed in the mission and wanted to be a part of it. So then there were a group of people who review the images and provide feedback. So anyway, I think through all of that, we were able to develop this system where people could have their images reviewed and have feedback to improve them going forward. And then through that also came the research possibility, which I guess is another interesting point, is how having a QA system ties into research aspects. If you have a QA system set up, then you can answer a lot of useful questions. So basically, we kind of were able to reach all of those goals through this.
Hi, this is Gordy Johnson. So I have to be honest, when I saw the title of this come across and some of the information, I think I texted Jamie right away and I said, this is exactly what we need, and was really excited about this paper. So I'm really proud of you guys. I want to start jumping results, if that's okay. Can you tell us a little bit about what you found here with what percentage of the time it changed management and changed your diagnosis? Michelle, can you start?
Yeah, absolutely. So we analyzed that in a few different ways. I'll start with just overall. So we looked at kind of all of this ultrasounds that we did. And just as a brief background on the methods, basically what this entailed was at 2 different sites, we had all of the learners at the sites submit all of the ultrasounds that they did and document the kind of their one-liner, whether or not they felt it answered the clinical question, changed diagnosis, or changed management. And so we had a total of 237 scans. 92% of those answered the clinical question. And that was kind of a subjective answer as to whether or not we felt it helped us clinically. 41% of them changed diagnosis and 41% of them changed management. And that was kind of over all of the scans. And then we tried to split that up more in terms of clinical question. And one of the things that we learned throughout the study is we had a lot of different clinical questions. That was one of our limitations. I think it would have been a little bit easier to pre-identify like specific clinical questions to analyze. So I think it would be more useful for me to just go through the ones that we deemed kind of highest yield. But within those, the ones we deemed highest yield were finding fluid, which included pericardial effusion, pleural effusion, or ascites. And within that, so 100% of those answered the clinical question. And then about 60% of those changed diagnosis and like 65% changed management. So that was really what we felt was the highest yield application of POCUS. And I think just anecdotally, a lot of us who use POCUS a lot would probably agree that finding fluid is one of the most high yield applications pretty much in all settings. So then the other...
I really like the way you sort of define it so specifically, but also as a general application, because over physical exam, which is, I think, a very enriching experience to engage in, physical exam in global health settings. I'm told, but that finding fluid by ultrasound is a confirmatory augment to physical exam in ultrasound wins. Let me ask you, this is also figure 3 in the article for those listening along. I wondered if you had an example of just of these categories about something that you can imagine one of the survey respondents would answer, that something answered a clinical question as opposed to changing a diagnosis or management. Like there was a clinical question that didn't change diagnosis. Maybe they thought that that ascites was present and they found ascites on ultrasound, so it answered the clinical question or confirmed it, but didn't change the diagnosis or management. Is there another example, just kind of the clinical setting? Because I think those that haven't traveled to these settings may not know exactly some of those distinctions.
Yeah, I think that's a really good example. I mean, sometimes they could get chest x-ray. So if you saw a huge pleural effusion that you knew was there, although arguably it still may change your management because you may be doing an ultrasound guided thoracentesis instead of a non-ultrasound guided thoracentesis. Another example would be of something that would be patient with like very clear heart failure, clinical syndrome of heart failure. Their volume overloaded, they have pulmonary edema. You look at their heart, isn't functioning well, but you already knew they had heart failure and you're already treating them for heart failure. So that might not change your diagnosis or management, but it would answer your clinical question. Does that answer what
Got
you're
it.
asking?
Yeah, that's really helpful. Thanks.
An interesting aspect about this to me too is to me whether or not it answers the clinical question is sort of a marker of can you get the images you need and the interpretation that you need. Whereas the change diagnosis, change management is more on the clinical integration side of, does it actually affect what you're going to do? And I suppose, if it answers the question, but it doesn't necessarily change diagnosis or management, it often is still helpful, in confirming the diagnosis. But then, so that's why I guess it was useful to have those as separate points.
Right. And in a resource limited setting, the access to other imaging modalities, I imagine, is sort of resource limited and also requires travel or transport or cost. Is that right? Yeah.
Yeah.
Okay. So I interrupted you, Michelle, as you were starting to walk us
No,
through
that's okay.
More about figure 3 with the sort of utility of the different applications. Were these pre-specified, like the abdominal TB exam, LV function, and then the lung exam, or these were just based on what the users were doing? This is the content that was evaluated.
The latter.
Okay.
Yeah, they were not pre-specified. And if you go to table 3, you can see that there's a lot of different clinical questions that we quickly learn. And part of this actually that was really interesting and useful for us, I think, as we went on, was just to learn what a reasonable POCUS question is. And more often, the ones that really helped and were able to answer our clinical question were the more binary POCUS questions, which I think we've all kind of talked about in the POCUS community a little. So for example, what is the qualitative LV function is a little more not binary, but it's discrete. Is there evidence of abdominal TB? Is there fluid in the space? But then ones that were a little more vague, like sometimes people would do evaluation for malignancy, which, as you can imagine, is incredibly vague. So things like that were the ones that were a little bit more challenging and probably should have been predefined more in advance. So we kind of picked the ones that were used more commonly and were concordant with that were just used more commonly.
I think that's so helpful to have, in table 3, if you were looking as a global health program that was starting to invest in POCUS curriculum or think about what applications could be used. So knowing from your study what the most common uses were, you could help tailor your curriculum before traveling. So I might think, for instance, that like in the hospital wards of the US, that like bladder and Foley would be a very common application for us maybe, but in this case, it was very low level of utilization. So just for example, I think looking at that table, a lot of readers may help to define their goals for a budding curriculum or make choices about what would be a priority for training in the global health setting.
Totally.
Can I jump in, Jamie, for a second?
Absolutely, Gordy. I was about to ask you what your take was on some of these applications.
Well, I mean, for me, I'm taking a lot of the messages from this paper home. I'll be honest. I mean, the finding the fluid thing was brilliant. And we just got back from Society of Hospital Medicine meeting together in a little debate about, credentialing, comprehensive credentials versus more of a stepwise or 2-level approach. And I just think this find the fluid thing is brilliant. And I'm not just saying that. I really think this was great. And it's, there's a lot of people, and I've realized with a lot of our partners that aren't necessarily going to do POCUS, but I think we can teach everyone to find ascites in the abdomen. And again, I love the simplicity. It can be as simple as present or not,
Mm-hmm.
And of course, the FASH is going to be pretty unique to the resource limited global health setting. But Michelle, you also alluded to things that you didn't put a part of this, but you think of the future you might, which I believe was hydronephrosis and Dvt. Do you want to comment on that a little bit?
Yeah, absolutely. So I think those are two applications of POCUS that are thought of as kind of ease. One of the things we talk about is like ease of learning. So can this be taught reliably to a novice learner who could then do them well? Cardiac is probably less something like that. Gallbladder is less like that. But Dvt and hydronephrosis are two applications that are pretty easy to learn. And binary as well, kind of like what I've been talking about. The reason that we just didn't have a high prevalence of that clinical question, at least in Malawi, and I'll let Steve comment a little more on Guyana, there really wasn't availability of anticoagulation in Malawi. So that was a little bit of a challenge. And we just didn't see clots in the same way that we do here. So we really rarely actually did those scans. And so that's why we didn't include them. And same with hydronephrosis. I think we only had like 4 scans where we were actually evaluating for hydronephrosis. But I do think, as we talked about in the paper, a lot of these middle income countries are so variable that I imagine there's plenty where those 2 applications would be extremely useful, and would be relatively easy to teach.
What about kidney size? I think you alluded to that a little bit in the paper. Yeah, tell me about that.
Yeah, that was really interesting to me, because in Malawi, we, as you can tell by how I'm talking, I was in Malawi, Steve was in Guyana, but in Malawi, we really couldn't get labs very often. So we could, but we would send off the labs. They would come back like 4 days later, sometimes. And so kidney size was interesting because if you thought someone had renal failure, the dialysis unit would only accept them if they were in acute renal failure. And so sometimes we would look at their kidneys and you could measure the size. And if they were really small, maybe you would, and didn't have great corticomedullary differentiation, you may surmise that they have more chronic renal failure. And so in the patients, or even not in the dialysis situation, but just a patient coming in where you're concerned that maybe they have like a renal etiology of volume overload or something like that. That was a really interesting application that we actually used quite a bit.
Interesting. What's a common cause of renal failure in that setting? Is it undiagnosed hypertension, diabetes, or?
We don't know. I think that less of that and more, a lot of them were more younger people. So there was a thought of like more autoimmune type of things, but I don't remember off the top of my head. And I remember doing a lot of PubMed searches to figure out why, but just because there's so little research into it, no one really knows, I don't think. Steve, do you know? Do you remember?
I don't.
One other question I had, I know we talked about these applications. I realize a lot of listeners may not have heard of some of these exams. So we mentioned the FASH exam, that's the HIV-associated TB. But can you walk us through that exam? I don't know, Stephen, or Michelle, if you want to walk us through what that exam is like. It's just audio only here, but tell us about it.
Sure. So I guess, and Michelle, maybe you could talk about it in more detail. You guys probably did it more than we did. One thing I should mention too, actually, about this is the study itself. And if you look at the population, 88% of the scans from the study were actually from Malawi, 12% were from Guyana. And actually, it's an interesting point in terms of the settings, because Guyana was actually a fairly different setting, a bit closer to what we would have here in terms of access to resources, but maybe some more time delays and these types of things. But so we actually we're not too often doing the FASH exam, but a lot of these other ones still apply. But yeah, maybe Michelle, if you wanted to talk about the FASH.
Yeah, sure. So the FASH exam, I had never heard of it before I got to Malawi, and I think it's called the Focused Assessment for Sonography in HIV-associated tuberculosis, and the reason it's called that is because it's the goal of the FASH exam is to help diagnose extrapulmonary TB, which is incredibly hard to diagnose in general. But it's really only validated and or sensitive in patients with HIV with CD4 counts below 100. And I'll go through some of the findings and it'll kind of become clear why. Jamie, you did didn't you just do the FASC exam?
Yeah, basically it's all borrowing from the behemoth success of the FAST exam. Right. To do a new protocol, you want to have it start with FAS.
Yes. But I think it's similar because a lot of the findings in the FASH exam also goes off of the FAST exam. A lot of the findings are the same. And the reason that the FASH exam is only validated in CD4 less than 100 is because really a lot of those findings can be seen in cancers or cirrhosis or a lot of other things. So anyway, it uses the model of the FAST exam. So it looks for fluid in all the different places, including the heart, lungs, abdomen. So it looks at all the different similar sites to the FAST exam. So right upper quadrant, left upper quadrant, to look for both pleural effusion and fluid in Morrison's pouch fluid in the splenorenal pouch. It looks at the pelvis to look for free fluid. And then it looks at the heart and the subcostal view to look for free fluid. So that's the basic principle of the FASH exam, but there are a few other components. One of them is looking for splenic microabscesses, which is more challenging to find, but can be seen with TB. The other is looking for abdominal lymphadenopathy in the same view as the pericardial effusion, as the subcostal window. And then the third is to look for like focal hepatic lesions. And so in one of the original FASH exam papers, it was separated into like the FASH basic, which is just looking for fluid, and then the more advanced, which includes those other things that I just mentioned. And so we kind of taught ourselves it a little bit, and still and felt that the sensitivity was, well, yeah, we still struggled a little with some of those other more complicated things like the lymphadenopathy and the abscesses.
Right. And it seems like a great approach to screening for those problems. I mean, whether heart failure could mimic, that scenario or not, I think it's a really interesting screening tool. And you mentioned already how, finding fluid with point of care ultrasound is is a basic skill that can be taught even, if you're not able to optimize every cardiac view, just, doing a basic protocol like that could be taught to, not even physicians or trainees, but other, providers on the ground, or nurses and other users.
Mm-hmm.
Also, extrapulmonary TB just being such a difficult diagnosis to make, I guess such utility in that sense to try to answer a question that was otherwise so difficult.
Mm-hmm.
Yeah, and a lot of times you're suspicious of it. And many of those places with FUO, they'll just treat empirically for TB.
Mm-hmm.
So again, answer the clinical question. It didn't maybe change management, but you'd be a lot more comfortable using those drugs, which, as you all know, are potentially toxic if you're seeing this abdominal adenopathy. And then in a lot of these areas, there's something I always say I learn a lot more when I go there than I'm going to teach, but there's the Liporabinoman test of the urine when they have a low CD4. It's helpful to rule in disseminated TB, and that's often available through WHO and other places because those TB programs are there, although other basic labs may not be. But you are going to miss some. There's going to be some lymphoma, but again, you're going to probably help those patients earlier and get to the diagnosis correctly earlier using the FASH exam.
Absolutely.
Really,
and TB treatment was, in Malawi at least, was actually like one of the easier treatments to get. They always have access to it. And so if you have a positive FASH exam in a patient with clinical suspicion, then it's a pretty easy treatment to start. And you're right, like sometimes we would just treat. If they didn't get better, then maybe it was more likely a malignancy.
It is ironic, a lot of times you can't get a CBC, but you can get an HIV viral load with this
easily.
program.
Yeah, way easier. Yeah.
Speaking of getting resources, curious to know, I'm sure users are wondering a little bit about, not with no disclosures, sort of what devices you had on the ground. I know some global health sites have sort of a donated old, very old, like OB type equipment that people are using. Did you travel with your own handhelds to these sites? Is your program supplying, cart-based equipment? I'm just curious.
Yeah, I think this is actually an interesting aspect of how the program developed, because we started off with, the track itself had one machine, which was basically usually brought to Malawi. Do you remember what machine that was, Michelle? I don't even remember because it was from the very beginning.
Sonosite Nano Max, the one that you can hold.
Okay, yeah.
Briefcase. Okay.
And then, but that was only one machine. We had multiple sites, and that has challenges, especially with trying to transmit images and these types of things. In Guyana, the site had machines. The residency program there had machines that while we were rotating, that we would use as well. And so that also has challenges, especially in terms of integrating with QA process. But a couple things. One was we ended up having a butterfly that we use, which was super helpful, especially in terms of the QA process for transmitting the images. And then two was actually, especially with some of the machines that we did have, trying to figure out a way to just move the images, in a reasonable fashion, from we had a GE venue and some GEV scans as well. And so developing the workflows to move those images. But I think that was basically the summary of the machines. Oh, and we had a Lumify, of course. You can't forget about the Lumify. Yeah. That was a really helpful machine too.
Yeah, it was interesting because I think that the program, like our program, evolved as portable devices became available. So like the first year that we did it, we had the Nanomax, and literally I was taking videos of it in a really brightly lit room to try and like text via WhatsApp pictures, and no one could see what we were doing because there was like no physical way to save the videos from the Nanomax without just taking screenshots or taking videos with your phone. Wow. And then year two, we had a Lumify and Steve had a VE scan, and then year three we had a butterfly, and so it just kind of evolved, but made it a lot easier for sure.
Wow.
And I think also with this type of setup, it was very important to integrate with workflow. And in that sense, having a machine that you carry with you was much easier than having to, go and find one and come back.
Along these lines, I'm really so curious of all of you, who do global health work, and this era is really a turning point in terms of having portability and cheaper devices. That is this a really important moment, in terms of global health applications for POCUS? I mean, do you see, have you heard from colleagues that that we're establishing programs like this for not just for trainees, but for sustainable programs on the ground? Is this really sort of a breakthrough moment to have imaging in developing countries? Like what's your big picture on that?
I think it is, for sure. It's so much, I mean, it was so much easier for us to be able to learn and get feedback on our images. I do think that the portable machine, and Gordy, you probably have more insight into this too, since I haven't been abroad for 2 years now, but I think the portable machines bring their own set of issues. So for example, the Butterfly, you need to have an internet connection, and we had to buy a SIM card for it, which for us was fine, but locally that would be a lot harder to do and to implement, and to have a tablet. And the other issue with the portable devices, and the Lumify was the same, so to upload them onto any kind of system, you need a SIM card because there isn't reliable Wi-Fi. This was in Malawi, but there isn't reliable Wi-Fi anywhere. And so to be able to do that is challenging. And then the other big issue with the portable devices too is like, there's the phrase like, it will grow legs and walk away. But it's just really hard to locally without someone owning it. Like we would just carry it home with us every day. But if we're thinking about trying to implement POCUS more locally without us there, then that is another really, really challenging aspect. Like there isn't somewhere to keep it and someone just needs to own it, but there aren't really those people. So it just brings its own set of challenges that were always kind of there. But I do think it's a big turning point, and it's still a big deal.
I have a couple of comments on that and a question. It's really helpful now with televisions, and you do need at least 3G to do that live. There's Reacts as a platform you can use with Sona sites and Lumifys, and then the Butterfly has its live teleguidance. Did you do any live thing while you were there? Yeah. No,
we because we actually brought the Butterfly and we're using it ourselves. And at that point, it was year 3, so felt pretty confident in our scanning. And we're doing some direct teaching of local providers there, but hands-on. So yeah, we hadn't done that yet, but that would be a really cool thing to try. We do that here at the U, though. We do we try and do teleguidance for some of our providers.
And you even alluded to that, I think, in some of your conclusions about things you might try to do in the future, and that's teach some of the local docs. And it's a great way to get involved with global health if you can do it through teleguidance and tele-ultrasound. Now you don't even necessarily need to travel, although we all love that. But the one take home I've had from that is it's really, when you go and do these teaching programs, it's really important to leave a machine, because it's very exciting for local docs to learn this. But then when you go home with the machine, that's kind of insulting, for lack of a better term. And they're cheap enough now. You can do a fundraiser, something simple on your home front, even if you don't have a grant from your institution to do that. So I highly recommend considering that if you're going to do some POCUS overseas. And then, of course, training the local docs is the gift that keeps on giving. I just got a text that some doctor was learning from someone who we had taught in Haiti, and that was the best news, because you think that program is living on, if these people are teaching their own local providers. And ideally, that's where we want to get to, right? It's where everyone's as independent as possible.
Yeah, we've explored that quite a bit. I think part of the goal of this paper too was to think about which applications to focus on. Because what I ran into in Malawi was that I wanted to teach everything and they wanted to learn everything, but then it wasn't practical to go there for even a couple months and teach cardiac ultrasound. So my takeaway, what I wish that I had done, is taught ultrasound guided procedures. I think that would have been the low hanging fruit to teach initially, is use ultrasound, because no one was doing it there because they didn't have one. And we have left a few ultrasound machines there as well. But trying to teach ultrasound guided procedures or just finding fluid is a really high yield thing to do that can make a really big difference in patient care. So that was my takeaway from trying a few different things that were probably too lofty, and what I would do in the future if I were to go back.
Yeah, we definitely found ultrasound guided procedures to be really high yield too, because if someone's already doing the procedure and then you can just add ultrasound to it, it's high yield in terms of amount of extra practice in order to improve your care with it. But interesting thing to me too about the educational aspect is the challenge isn't even just teaching it. It's then the ongoing longitudinal mentorship, and kind of practice-based training. And so, especially with global health, I think this becomes especially important, especially with people who are visiting and then going back, is, you can go and teach, but then, then what about that ongoing longitudinal aspect? So I think that's one of the kind of powerful things about this type of longitudinal QA system too, is it enables that partnership to, continue to work. Is it could work in an ongoing fashion, so that even if someone's in a different continent, they can, provide feedback on your scans.
Amazing. It's really incredible to hear your take on all these different issues. Raises a lot of really important questions for future studies and future global health work. I'd be remiss if I didn't ask you to just to round out your take on the results of the study. I know our listeners can find the article for free on POCUSjournal.com, but in figure 4, I know you took the images that were reviewed, and there was some other analysis you did. I want to make sure you had a chance to just comment on sort of the conclusions from the study and like level of agreement between reviewer and resident interpretation and some of those aspects. I figure 4 and 5.
Yeah, absolutely. I'm just pulling it up so I can make sure I'm speaking correctly. But our real goal was to define a curriculum that can be kind of universal, knowing that there's differences in different low middle income countries. And the way that we did this is we looked at 3 different things. So we looked at ease of learning, or prevalence. I'm going to start there. So we looked at prevalence. So which applications did we use the most? We looked at ease of learning. So based on literature review and what we could find, which exams are reliably easy to do with just a short period of training. And then we looked at our findings on impact on diagnosis and management. And that kind of helped us come up with a few different things that we felt would be highest yield. And so the curriculum that we've proposed is really just starting with finding fluid. So is there pericardial effusion, pleural effusion, or abdominal free fluid? And then gross LV function. So what is the qualitative left ventricular function? Is it good, bad, or terrible? Not trying to be, echo text or anything like that. But we felt like starting with those 2 applications based on what we found is really where is really high yield for any kind of global health POCUS curriculum. And if I were to go back and do it all again, that's where I would start, plus minus DVT and hydronephrosis, like we had kind of talked about before, depending on the prevalence in the specific country. But our countries didn't have particularly high prevalences of those 2 things.
Got it. Really outstanding. And I think the readers are going to get a lot out of sort of the analysis you have of these different parts of a program, but wanted to just sort of round out our discussion here about seeing if you have any advice for global health programs that aren't using POCUS, like just even sort of brass tacks advice about how they would residents who are in a global health track and in a U.S. program who don't have POCUS, any advice for them, or as they approach their global health faculty or administration around getting support or funding to include POCUS in their curriculum, advice for them or advice for the faculty who are trying to learn is in the GME setting. If you have any input there.
Yeah, I think the advice that I would have, or the thoughts, I suppose, would be that definitely there need to be multiple ingredients in place in order to start doing ultrasound, of course. But it can be done in a stepwise fashion. And something that I've found, at least especially at UPMC and Cleveland Clinic, but in general, is kind of the role of having an educational scanning process and policy as part of the development. Because if you're planning to just start something, start a POCUS program, we have to have credentialed, a group of credentialed people. We have to have machines. We have to have a QA process. We have to have this. We have to have that. And there are a lot of barriers, and then you end up spinning your wheels. And so I found that starting with building the community, having an opportunity for educational scanning in a safe fashion that, that doesn't cause any trouble, and there's a policy around it, so that people can learn, and then eventually through that, then that builds the momentum. Of course, you have to have machines too, but then with that, then those people who've been doing that become trained, and then then you can eventually get credentialed people, and then it eventually builds on itself, and then it's a multi-year process. I think in the at least for us with the global health track context, it was a little bit different because it already existed. We didn't necessarily start it. We were trying to improve it. But I think also that the role of ultrasound was much more clear in the global health context, in the sense, especially if it's more difficult to gather imaging, then ultrasound can play a more obvious role, and so it becomes a little bit more pressing and pertinent. But a lot of the other same things apply. So anyway, those would be kind of my thoughts on it.
Michelle, do you have any advice to the intern in a global health program who's doesn't have POCUS, and they're looking to get faculty to donate time or resources or get equipment for the application?
Yeah, I mean, similar. I echo everything Steve said, but I think, and I feel like a broken record a little, but I think just thinking about the low-hanging fruits. So not trying to overdo it a little, but really just thinking about what can I practically do as an intern? Most interns probably will at least know how to look for fluid. So just think about the low-hanging fruit. What can I do? If you got one butterfly and we're able to try and look for fluid, that would probably make a huge impact wherever you are going. And I think that's something that can easily be done. I would also harness the power of social media a little bit, potentially to try and network with other providers. I've met so many different POCUS people on Twitter, for sure. Steve and I have definitely had a good Twitter experience with POCUS. And so I think trying to network that way, I guess speaking as a POCUS faculty who doesn't have a ton of time to review images, I still feel like reviewing images from global health would be super duper fun. And I'd be really excited to do that for anyone. So I think a lot of people with a passion for global health would be happy to network and figure out a cool way to help out interns.
Right. Even those faculty that aren't able to travel, can still participate in the image review. And I think that your study highlights how significant that role can be, that reviewing now with image QA transmitted, whether it's real time or after returning to the US, that they can really play an important role in education and continuing to educate learners about their scans by reviewing images, which I think is a really neat point you guys make so clearly.
Yeah. And I think just also acknowledging that there's so many resources out there. A lot of us are kind of self-taught a little bit in POCUS, and there's so many YouTube stuff. There's so much via SHM and ACP that offer kind of maybe not free, but educational content. So I encourage that as well.
Outstanding. Well, it's been such an amazing, almost hour to get to chat with you all. I know Gordy is going to have some closing remarks. It's really so neat to share this opportunity to chat with you, but also highlight how significant the time that you put into designing this study and getting the IRB approved and collecting the data and reviewing the images. I mean, it's a Herculean effort, and it's so important to have out there in both for global health and for internal medicine POCUS. It's really commendable, and we're really privileged at POCUS Journal to have the chance to be a platform for your article, and it's really an honor. And thank you both so much for you're putting the time in here and training the next generation of POCUS users in global health. But I won't close it out just yet. I'll see Cordy, I'm sure, has some closing remarks or questions.
Yeah, well, first of all, I want to say congratulations. I really do think this is a great paper. It's changed my practice. I have borrowed your find the fluid mantra. I think it's wonderful. And we talk a lot about elevator speeches, and I would just say, if you're talking to your administration to start a program like this, it's now affordable. All the competition between the companies is great. It's making the technology better. It's bringing the prices down rapidly. Provider patient satisfaction, patient safety, and like Jamie said, it allows all of your residents, trainees, or even your faculty to get involved, local partners with the image interpretation. When it's done live, it's very exciting. We had a case we did in Haiti live and made the diagnosis. We're going to do a grand rounds in Norway and in Ghana in June. So it's really a lot of fun. But congratulations to your whole team.
Thank you guys so much. It's been really fun revisiting it.
Wonderful.
Yeah, for sure. Yeah, because this was definitely a meaningful aspect for us of our time in Pittsburgh and with Global Health Track, and so yeah, it was nice to be able to chat about it. So appreciative to be a part of this.
Thanks again for joining.
Of course, I do have one question for Gordy, perhaps, is just what would you see as kind of I don't know, maybe the next direction or next steps for this area of research, in the field as a whole, global health and POCUS education and this overlap?
That's a great question, Stephen. What I've found from most of our training is we'll get people really excited, like the week that you do before people went, or maybe even when they're over there. But the problem is you come out of those situations and you'll talk to people 6 months later. And in my experience, about 20% of people are still scanning. So the challenge is to keep those people involved. And I think it's really an ongoing program, again, where ideally, if you would have left a device behind and then had a regular check-in, like you said, bring it out to train some of the local providers. And then just with expectation, we'll be checking in every 3 months for a morning report, from Malawi, and here's some cases, and just keep them scanning. Like we say, you can teach a person to ski, but the only way to learn is to go down the hill, and you got to go down a lot of hills before you get it, right? And if you don't ski for 10 years, you're not going to be very good. And I think it's ultrasound. Right.
I think, the interesting point that brings up too is the relationship building aspect of this, and what makes it, pretty interesting and fun is, and as we go getting to know people and then hopefully maintaining that relationship and, being able to support POCUS development in an ongoing fashion, like you mentioned. And, I know we're definitely very appreciative of our partners at these sites, who welcomed us there. And, like you said, the ability of this to have a, form of continuing impact is one of the potential benefits of it, I think, from our perspective too.
Awesome.
Excellent. So great to meet you all. We have to close out, but really appreciate you taking the time to to join us on this call, but also on putting so much effort into this important work. Congratulations again.
Thank you so much.
Thank you so
Great
much
chatting
again.
with you guys.